Good evening, friends and family. This is Dr. Rogers Kane. I am coming to you from Jacksonville, Florida, per usual. We are very excited this evening about a topic that many it has touched many of us, if not all of us, in one form or fashion. It could either you have a cousin, aunt, relative of some sort, mom, sister, you name it, or just a friend, a family friend that may have suffered from something as it relates to their memory, whether it's Alzheimer's versus dementia. Our special guest this evening, well, before I do that, let me let you know that Miss Jocelyn Turner had some other issues, concerns that she needed to address, so she won't be with us this evening. So our guest co-host is going to be Dr. Kelly Tice. Get familiar with Kelly's face, even though she's been here before, but she will also serve as our guest co-host in the future. She's the president of Northeast Florida Medical Society. She is also Vice President of Medical Affairs, Chief Equity Officer for Florida Blue. In addition, we have Dr. Philip W. Tipton. Dr. Tipton is an associate professor of neurology at Mayo Clinic, Florida, and they both of those guys, their accolades in detail can be seen at our website, which we will post a little later. With that being said, I want to get right to the meat of the matter, and um, and Dr. Tice, I'm gonna turn it over to you, playing go co-host, because I am gonna serve a dual role this evening in terms of helping the host, but also trying to bring Alzheimer's from a primary care physician perspective. However, with that being said, um, Dr. Tipton, what can you tell me as to the difference between dementia and Alzheimer's?
That's a great question. And I start a lot of my presentations with that very question. And I usually poll my audience to see who thinks it's the same thing and something different. And most people usually refer to the two as being the same thing, but that's actually a misnomer. And just in the few years that I've been in training and in practice, my definition of how to distinguish the two has changed. So I think it works out best to start with defining what dementia is. And really, it's on the spectrum of indicating severity of cognitive impairment. So let me word that a little bit different. That it's um, if you think about cognition, you can have impairment of cognition. It could be mild cognitive impairment, or it could be more severe, and we call that dementia. The difference between the two is that in mild cognitive impairment, yeah, there may be some symptoms, maybe some concerns. And if you go and talk to your doctor about it, they may do a memory screen, test you on a few things, and they can measure that, yeah, there are some things that are abnormal. However, it's not severe enough to interfere with someone's activities of daily living. So, you're still driving your car, you're still able to maybe manage your finances or manage your medications. You're still doing those things. But when we really do measure down to it, there is a decline from someone's previous level of cognition. The difference, though, when we move into the sphere of dementia is that now that cognitive impairment is severe enough to interfere with those activities of daily living. So, maybe someone's spouse is serving as their navigator, and they're having more difficulties navigating in the car, or maybe there's some oversight with medications because an individual is forgetting to take the medications, or double dosing medications. So really, dementia is an indicator that things have gotten severe enough that it's interfering with daily life. Alzheimer's is one cause of dementia. There are lots of things that can cause dementia, and so I tell people. In fact, I was telling a patient today. I said, if dementia, there are lots of things that can cause it, just like there are lots of things that can cause a cough. So you wouldn't be too satisfied if you went to Dr. Kane with a cough, and he said, "Well, I figured out what's wrong. You've got a cough." that probably wouldn't go over very well. You would probably want to know what's causing your cough and what to do about it. Well, Alzheimer's disease is one cause of dementia, but there are many other causes. It is the most common cause of dementia, but there are many other causes. And so it's important to have a good thorough evaluation with your physician to understand, are we dealing with a neurodegenerative disease like Alzheimer's, or is it another neurodegenerative disease, or is it something altogether different? So the way that I look at it is Alzheimer's disease causes dementia, but there are many other causes of dementia.
And Dr. Tice, you can go on ahead and take the lead at this point, with one exception. For those that are not medical nomenclature inclined, cognitive.
Yeah.
Explain what that means.
Yeah. So actually, I think it's worth revisiting a little bit in Dr. Tipton's explanations so that we can be sure folks are tracking. Cognition simply is sort of thinking, processing things, and you described something, Dr. Tipton, that I think is really important, and I'd like to call out here as well, and that is that dementia, that impact on your thinking and your ability to sort of do your higher functions during the course of your day. When we get to the point where your daily activities are impaired and you're requiring some assistance, or I think many of us may have experienced with loved ones, they're covering that they have deficits and in certain places they're unable to do things, they're constantly losing their keys, or that sort of thing. One of the concerns is whether or not this is caused by something that is treatable and interrupts it and sort of cures it, or is this you described Alzheimer's as being being a progressive illness. And I think that's important to call out. There are other things that can cause impairment, right? That a medical workup will identify. You get managed, and it resolves or improves. And then there are other things that we wouldn't expect that to occur. Can you give maybe a couple of examples of something that might look like a progressive dementia like Alzheimer's is, that could in fact be managed?
One of the most common things that can look like dementia is depression. In fact, sometimes we refer to it as pseudo dementia because it can look almost identical to dementia, and it really takes drilling down on it with specific cognitive testing, really, to differentiate it. And the good thing about that is there are dozens of medications out there that are indicated for the treatment of depression, in addition to talk therapy. So the combination of medications and talk therapy can be very effective in managing depression. There are also
Go ahead, Dr. Tipton.
No, you're good. Go right ahead.
I was going to say, as a primary care doctor, I've seen that quite frequently. That whether it's the depression, and then some other things that I've seen as a primary care doc. A lot of times, some other medical illness, such as low sodium, a urinary tract infection that has gone global, as I call it, to some of my patients that have become more systemic than anything else. The thyroid not being up to speed, and your ability to think and your cognition is somewhat diminished, and so on and so on. So there are multiple reasons that multiple other causes, Dr. Tice, as a primary care, for me to tune in with that I've seen happen, and that's when it's left up to us. And of course, when we look at all those things and we don't see an obvious cause, it's the spotlight goes then back to Dr. Tipton.
Right.
Yeah, and it's so important to rule those things out as well. And so when we see people in our behavioral neurology clinic first, we're checking those things off the list if they haven't already been done. So it's incredibly important point.
Right. I think one of the questions that I'm sure our viewers and listeners have is, if I'm concerned that myself or a loved one may be experiencing signs of dementia or Alzheimer's, what do I do? And how do I know what it is, and how worried should I be? And what you've said, Dr. Kane, is, we want everyone out there to have a medical home and really begin the evaluation of it with your primary physician who knows you. It's so important to be able not just to have the memory assessment that can be done in the office, but also to have a clinical person who has a relationship with you, who can observe really any differences, right?
Right.
One of the things that I've heard pretty frequently is, when you can sort of get up the nerve to go to the physician's office, often it requires some convincing, right, that there's actually something going on. So, very important that, you have a rapport, especially as you are caring for aging members of your family, or you yourself are aging. I think that's a really key point. Is this something that you see more often in certain genders, or does it, is there something that you can say increases the risk for this sort of thing, Dr. Tipton?
And include, Dr. Tipton, whether or not there's a racial preference to this as well.
Yeah, absolutely. So the biggest risk factor for neurodegenerative diseases, and let me step back for just a second, because to go back to our pre-conversation of getting into the jargon, I want to make sure that everyone's clear on what I mean when I say neurodegenerative disease. So neurodegenerative diseases, I know it's a terrible word, I stumble over it every time I say it, include diseases like Alzheimer's disease, Parkinson's disease. And what they're really referring to is that something's happening in the brain that's causing neurons, i.e. brain cells, to die. So the brain cells are degenerating, the neurons are degenerating, ergo neurodegeneration. And the hallmark of these neurodegenerative diseases, most neurodegenerative diseases, I should say, is that they're slowly progressive, as you mentioned, Dr. Tice. And so to also kind of dovetail on another point, you mentioned that it's important to get involved and have a primary doc, someone that knows you and can kind of put everything into context. And I think that I would echo that and take it a step further to say that oftentimes when we're trying to understand whether or not there is an active neurodegenerative disease, seeing what someone looks like just in front of us in that snapshot of time really only tells a portion of the story. It's like opening up a novel and going to one page and trying to figure out what the book's about. That's really hard to do. And so being able to put it into context and construct what we call the temporal profile, so how things have progressed over time, really starts to put into context what's happening with the person. Because these degenerative diseases, even Alzheimer's disease, can present in a number of different ways. And it's piecing that story together that really helps us to narrow down the differential diagnosis, or the number of reasonable possibilities, as we say. But to go back to your question, Dr. Tyson and Dr. Kane, age is the biggest risk factor for these diseases. If you look at, there are some, virtually gruesome statistics that show the rise of Alzheimer's disease in the United States, and it's moving at a rapid pace. But if you look at the breakdown of age groups in those people that develop Alzheimer's disease, the older, the more prevalent. And so that's important because we have an aging population. We always talk about the baby boomers, but overall, I mean, we have an aging population. So just from that standpoint alone, the numbers of Alzheimer's disease, individuals with Alzheimer's disease, is increasing. From the standpoint of racial discrepancies, there is a difference. In fact, I was looking earlier today. I'm going to get a little bit into the weeds here. So I was told that there's an electronic buzzer that will keep me from going too deep into the jargon. But one common question about Alzheimer's disease is it genetic?
Mhm.
And usually what someone's getting at when they ask me if it's genetic is, my mom had it, what are the chances I'm going to have it? Or I've got it, what are the chances my kids are going to have it? And so that kind of genetic relationship where it's hitting every kind of level in the family tree, that's really rare. We're talking less than 1% of individuals with Alzheimer's disease. And among those, it's actually more often those that have early onset. So onset before the age of like 60, 65 kind of thing. So genetics from that standpoint plays a very small role. However, there is a gene called ApoE that gets thrown around a lot in terms of Alzheimer's disease. Sometimes people say, oh, it's the Alzheimer's disease test. Not entirely true. And I think we may get to that later. But ApoE can be a major risk factor for Alzheimer's disease. So we can have different forms of this gene. We can have the number 2 form, the number 3 form, or the number 4 form. I have no idea what happened to the number 1 form, but that's how we name them: 2, 3, and 4. And the baseline risk. So when we're talking about your chances of getting Alzheimer's disease, we deal in terms of risk. And so if you've got a 3, and to make matters more complicated, we have 2 copies of this gene. So you can have a 3 and a 3, a 3 and a 2, a 2 and a 4, any combination of those. So if you've got a 3 and a 3, that's kind of considered baseline risk. But if you've got one of these 4 copies, we call it the ApoE4 allele, that increases your risk of developing Alzheimer's disease by 2 to 3 times, 2 to 3 times the normal population. But if you've got 2 copies of the 4, ApoE4, depending on what papers you read, it can be anywhere from 8 to 12, even some people say 15 times a greater risk of developing Alzheimer's. However, we're talking about risk, so not a guarantee. There are plenty of people out there walking around with 2 copies of the ApoE4 gene, and they don't have Alzheimer's disease, at least not symptomatic Alzheimer's disease. But the reason I bring that up is we know that the prevalence, so how common those different gene types are, differ from Europeans or Caucasians and African Americans. And so I think that's just one sort of relatively easy way of illustrating that even though we believe that there are similar disease mechanisms when it comes to people of different races, there are crucial differences in terms of the risk factors. And we're not even close to fully understanding all of those right now.
Well, one of the things I want to bring out, because you guys have mentioned, and both of you guys mentioned earlier, is that, you start to, you kind of look at this patient and you start trying to figure out, the family comes to you and said, Dr. Kane, I think my mom may be having Alzheimer's. And they want to bring their parent or, whether it's mom or significant other, whomever the patient may be, they want to bring them in for me to evaluate them. And like you said, Dr. Tice, first you got to convince them to come in. We get beyond that. Trust me, that first 5 to 10 minutes, those guys are good. They already know what, as a primary care guy, they already know what you're trying to do, and they're on it, and they can fake it. Believe it, I call it faking it. They can fake it for the first 5 to 10 minutes. So a physician who comes in and wants to run in and see the patients and run out, not going to pick it up. Obviously, there's some questionnaires out there, but those questionnaires give them time to think. And so they can, once again, plot around your diagnosis. But if you're going in and you're evaluating the patient, I tell my patients, my office, I tell them, if this, if I know it's about evaluating a patient for memory-related issues, I either make them the last patient for lunch or the last patient of the day so I can have enough time to discern, they trying to, for lack of a better description, BS me or just what? Because they are good. They can really snow you and not, if you're not paying attention, they can get you. So I'll, Dr. Tice.
Absolutely. I think what you say raises a few important points. There needs to be an awareness on the part of the physician, but also an awareness on the part of the caregiver or loved one that may be, supporting the patient to and through that visit. What I understood you to say, Dr. Tipton, in terms of the APO gene and APOE 4 allele, it's more common in Blacks and African Americans. Is that right?
Well, it depends on which allele you're actually looking at, and so I don't remember off the top of my mind the relative prevalences between the 2s and the 3s and the 4s, and then you can mix those up. So it's not clearly an increase in everything. It's
different.
It's a completely different makeup. Yeah.
Okay, that makes sense. One of the things that I'm sensitive to is, in addition to kind of a discussion about progressive or worsening dementia like Alzheimer's, we also want to be sure folks leave this conversation with a few tools, a few nuggets in terms of how they might better manage something they might be observing, in a loved one or even in themselves. I frankly was a little offended at this question I saw that popped up that said, if I leave the room to get something, and then when I get there, I don't remember what I went to get, should I be tested for dementia? Because, I need a workup if that's the case. But certainly I think, all of us have experienced that to some degree. And, I think the question that I would pose to both of you is, if it's happening to me or to someone I care about, what should be the trigger point? At what point, is it before it has the opportunity to impact my ability to perform my routine activities of daily living, or is it appropriate to wait until you see some significant impact?
I will go first simply because I see them first, and before I send them on to Dr. Tipton. It's a difficult question because I've walked into the room and it's like, what did I come in here for? And then it may click. Okay. I've had patients come to me and complain about having memory related issues. And sometimes what they describe, I'm going like, well, I'm not so sure that may be of a concern. And then I step back and say, well, if they expressed enough of concern to me, that one question that they asked me does not involve everything that is happening to them, or didn't give me the opportunity to discuss all of the things that are happening to them. So I have to get into more detailed questioning when they do come to me and mention something along that line. In particular, ask them, some of the things I ask is, if they're married, has your spouse said anything about this? Okay. Are you forgetting to pay certain bills? Are you forgetting some things that you normally would do to where it would, it's not even it doesn't even take a second thought or a 10th thought to do it. If you're still a working individual, is it affecting your work? Is it affecting, how you, what does it affect? So, because I can list a whole slew of things as a physician that I start to try to narrow down some of the things that they truly may be experiencing. And there's not one easy answer to it, but it's just a more detailed investigative questioning is what you have. That's why I say it takes time to discern these things. Dr. Tipton, can you?
Well, before you respond, Dr. Tipton, I want to say something. As a primary physician myself, one of the things that I would often say is, I don't expect you to be the doctor, right? I don't expect you to be the doctor. So if you have a concern, I think it is appropriate to address that concern with your physician. I don't expect you to, I wouldn't expect you to stay home and try to figure out whether that pain is heart attack or acid reflux, right? As a matter of fact, we wouldn't want you to do that. Similarly, if we're talking about a dementia, for instance, that will worsen, right? We would want to talk about how to interrupt that, how to manage that. So, early evaluation, even if it takes, a visit or two for it to declare itself, is probably valuable. Dr. Shipton, I want you to respond to that question. But also, if you could, in your remarks, would you also talk about, what the workup looks like? Like, how do we know when I leave your office that our loved one does or doesn't have Alzheimer's?
Yeah, I agree with both of you. I'm of the, I don't know, maybe this is just the way that I'm wired, but I like to know as much as I can about things. And I think that knowledge is power in this case. And so if you've got a concern, talk about it with your primary care physician. And, often I like how you worded that, Dr. Tice. I mean, I think we all pay good money to get these degrees, and if you're able to do my job, I'm going to be kind of upset about that. So, and if not, I need to get my money back. So, but yeah, I mean, all joking aside, I think if you've got a concern, have a detailed conversation with your physician, because we would hate for you to be walking around thinking that you've got a disease and your thyroid is low.
Right.
We would hate for you to think that you just need to take more B12 to make your thinking better, and you have a neurodegenerative disease. So those are things that it's our job to tease apart. And I love it when my patients come to me and they say, I've looked into this and this and this. But at the end of the day, that's not something that you should have to worry about, because you're coming to us for that. So I think if you have any concern at all, have that discussion with your physician. And if it's needed, they'll ratchet it up to the next level. And so to get to your point, what is the next level in terms of workup? Absolutely. First thing you got to do, as Dr. Kane said earlier, you got to rule out those primary medical things that can contribute to cognition. If vitamin B12 is low, well, you're going to supplement it. If vitamin D is low, you're going to supplement it. And I hope that at some point we'll talk about vitamin supplementation tonight too, because that's an important thing to touch on. Good. But beyond that, if we've ruled those things out, then the evaluation, when someone lands in my office, I'm going to take a thorough history. And after that, I'm going to examine someone. And based on my history, I'm going to tailor my exam to look for certain aspects within the nervous system so that I can start to piece together, does this look like, your typical Alzheimer's disease? Or does it look like one of the bazillion other neurodegenerative diseases that are out there but aren't as common? Because they all have their own sort of unique flavor. And to evaluate that, oftentimes in your office, maybe your primary care doctor's office or my office, we'll do a cognitive screen. Some of the most common ones out there, the MMSE, which is the mini mental status examination, and there are a lot of other ones like that. These are just cognitive screens that are meant to take 5-10 minutes in the context of an office visit and gives the physician, the practitioner, an idea of what's going on. It's not the end-all be-all. It is definitely not the ground truth, because there are a lot of caveats to those types of exams. But if things are still looking like something's not quite right, then we again may go to the next level. And so that could involve taking a picture of the brain, not with a Nikon, but with a potentially a CT scan, or better yet, an MRI of the brain. So that allows us to actually look at the structure, kind of the brick and mortar of the brain, and see if there's anything abnormal. Sometimes you can have cognitive impairment because you've had a stroke. Sometimes you can have cognitive impairment because you've got a tumor, in addition to all these other things we've talked about. But there are also changes that one might expect to see on a brain MRI that would point us towards Alzheimer's disease. There's a really cool structure in the brain that looks kind of like a honey bun, and we've got two of them. They're called the hippocampus. My daughter calls it the hippopotamus. She hears me say hippocampus and she says, "It's a hippopotamus."
That's great.
And I'm like, sure. If that helps you remember it, sure. So, but the hippocampus in typical Alzheimer's disease, it gets small. And the interesting thing about that is that the hippocampus is an area that's critically important for the processing and storage of memories. Well, that kind of makes sense, doesn't it? Alzheimer's disease, typical Alzheimer's disease, we have pretty big issue with memory early on. And so it makes sense that there's a structural correlate of those symptoms that people are having. So brain MRI can be really helpful. We may get more detailed cognitive testing. So I told you those cognitive screens really aren't the end all be all. They don't take into account race. They don't take into account age, oftentimes, level of education, culture. All these things factor into how someone performs on a test. We have a test called the MoCA, the Montreal Cognitive Assessment, and it's kind of like the MMSE, but they've got it in a bunch of different languages, like 20, 30 different languages. And I had a patient, I don't even remember the language now, but I didn't speak it. And I said, oh, I'm going to be real clever. I'm going to use the MoCA, and it's going to be in this person's language. I think it may have been Arabic. Turns out, to administer a test in Arabic, you need to be able to speak Arabic too. So those tests are out there, but I just say that kind of as a joke that it is important that our tests are culturally, racially, age, education appropriate, and formal neuropsychometric testing or neurocognitive testing takes those things into account. And what we get as practitioners from that testing is almost a map of what your cognitive domains are doing well and what they're doing not so well. And when I say cognitive domains, the one we've really been picking on today, which gets picked on a lot, is memory. But there are other cognitive domains. Even language is a cognitive domain. Visual spatial skills is a cognitive domain. And there are about a half a dozen different cognitive domains. So from the neurocognitive testing, we can see relative strengths and weaknesses, and we're able to localize within the brain where the problem might be. So neuropsychological testing really can play a valuable role in our workup. So I would say, kind of in addition to the basic medical, the primary medical issues, an MRI and neuropsych testing can go a really long way.
Very good. I love your responses, and I just want to pause here and point out something. We talk about health disparities, and in fact, the sort of the purpose for this podcast is to have discussions about things that that may be the framework or the foundations for what we call health disparities, where certain segments of the population have a higher burden of illness or disease. And one of the ways to solve for that and address that is through programs like this, where we are sharing information. But you have demonstrated a few things, Dr. Tipton, that I want to highlight for our viewers and listeners, that I know that our viewership sees with their regular exposure to Dr. Kane. But I want to sort of declare it here with Dr. Tipton's comments. One is, you said that you love it when patients show up and they've done some research, right? One of the things that we do really intentionally is empower members of our community and our patients in particular to gather information in preparation for their visit to a physician's office. And I have gone a step further and said, if you get there and the physician that you are seeing feels challenged or has an issue with that, that's a red flag, right?
Because,
that's a great point.
Right, you get your healthcare dollar and you go shop somewhere else. So that you said
that
I really value significantly. And then that you brought up the fact that some of the tools that we as physicians use in the evaluation and care of patients, the tools themselves were created from a population that wasn't diverse. And so often the tools we use can present a distorted view, can be inaccurate, can underdiagnose or overdiagnose, right? We see it in the psychiatry field. We just see it in a number of different places. So the call out about the importance of the definitive, the specific testing for a diagnosis as serious as this to be specific to and address your cultural background, your literacy level, et cetera, is a tremendous call out that I wanted our viewers and listeners to understand. It's important. We are diverse, and how we show up with the various diseases really, can change. So we've talked about the, what you should watch for, and if you get concerned, we've encouraged you, I hope, to go and see your physician. We've given you an idea of what the workup might look like. And when Dr. Tipton, say now, I'm seated in your office, or maybe I've just come from an office visit with my mother, and she's been diagnosed with Alzheimer's. What next?
Yeah, great question. I'm going to answer your question. I want to go back just for a second to the testing, because I think it is worth noting kind of what's happening in the field right now as far as the testing. And so in addition to the MRIs of the brain, we've got some other imaging that we might do where we can actually look at the underlying function of the brain. It's called a PET scan. We even have the ability to kind of look for what we refer to as the pathologic hallmarks of a disease. So in Alzheimer's disease, for instance, you may have heard us talk about the plaques and tangles, Alzheimer's, the plaques and tangles. What are we talking about? So plaques are what you see if you look at the brain of someone who is no longer using their brain. And I'm not just making a joke at Florida Gators fans. Oh, I had to slip that one in there. Sorry.
Okay.
Sometimes it happens.
Here.
I'm not going to tell anyone where I'm from. They're just going to Google it. But at any rate, so plaques and tangles, the plaques consist of this abnormal protein called amyloid beta. And the tangles consist of this abnormal protein called phosphorylated tau. So those are the signatures. That's how, if a pathologist looks at someone's brain in an autopsy, they could say this person had Alzheimer's disease because they saw those things. So we know now that those deposits are happening in the brains of people with quote unquote Alzheimer's disease long before the development of memory issues, long before the development of dementia. And so there's been a big push, rightfully so, in the medical community to try to identify what we call biomarkers, a way of detecting a way of detecting a disease outside of just what the patient looks like in front of you. And so if we could detect those plaques or tangles, or more specifically, the amyloid or the tau earlier, then we can start to identify people who are going to develop symptoms earlier. And I know a lot of ifs here, but if we can identify people that are going to develop symptoms, that's when we have a better time or better chance of changing the trajectory of the disease. So either slowing the time of onset, or slowing the rate of progression, or what we all want to see is preventing the development of symptoms, period. And so one way, we've actually had this available for quite a few years now, is with a lumbar puncture, so a spinal tap, we can actually measure amyloid and tau in spinal fluid. Now, we don't have people knocking down the doors to have a spinal tap, but that can be a very useful test to look for biomarkers of Alzheimer's disease. And we've got imaging markers that are now able to detect those. For the most part, those are used in the research sphere, but they're coming into play now, especially as we have new treatments for Alzheimer's disease that are kind of knocking on the doors of being available. So, but now, sorry, I know that was a big digression, but I thought it was pertinent to put in there. So Dr. Tice, you were saying you've got a diagnosis of Alzheimer's disease. What happens now? Well, so the big thing, and I would say even before you have a diagnosis of Alzheimer's disease, we're going to talk about lifestyle. before we even talk about medications. And there's a big reason for that. The big reason is that the medications aren't very good right now, just being completely transparent. But the big thing that I harp on is exercise, aerobic exercise. And my definition of aerobic exercise is anything that makes you hot, sweaty, and tired. So what I'm really getting at is something that gets your heart rate up. I've got patients that'll say, well, I go on walks with my girlfriends and we get our steps in, and I say, wait a second. So you're talking to your girlfriends while you're walking, right? Oh yeah, we have great conversation. If you're walking slow enough that you can have a good conversation, you're not walking fast enough. So you got to have that aerobic exercise. But the reason why I harp on that is that there was a study that was published a few years back that showed the benefits of exercise, specifically in Alzheimer's disease. It was a study of people that carry one of those genes that I mentioned earlier, not the ApoE, but those genes that guarantee you're going to develop Alzheimer's disease. We call them deterministic genes. And so it makes for a really unique population of individuals because they're going to develop disease. And since it hits every generation of the family, you can look backwards in time to see approximately when someone should develop symptoms. So you look back at my grandfather and you say, oh yeah, Grandpa developed symptoms around the age of 53, and Mom 55 or so. And so I'm probably going to develop symptoms around that same time. So what makes that unique is that you can take a look at people that develop symptoms earlier or later than expected and see what they're doing. What's the secret sauce? And with that approach, we found out that those people that exercised 150 minutes per week had a 14-year delay. Hear it, 14-year delay in the onset of symptoms. There is no medication. Yeah, you don't hear about stuff like that in the medical literature. I mean, when I saw it, I was like, excuse me, say that again. You don't hear stuff like that. There's no medication that comes close to that. So the big question is why? And it's a hard thing to study, because if you want to randomize it and you say, we're going to take a bunch of people, we're going to make you exercise, make you not exercise, come back and let me know, did you exercise? Oh yeah, I exercised. It's a very difficult study to do. So, but what we know from animal studies for the most part is that exercise tends to increase levels of neurotrophic factors. And what are neurotrophic factors? Those are kind of like fertilizer for your brain. So the brain has an amazing ability to kind of rewire itself, develop new connections, prune out ones you're not using, turn ones that you're trying to use into into stronger connections. And it's neurotrophic factors that allow our brain to do that. The word we use for that is plastic. And so the brain is plastic. And so we really think that that's the big reason why exercise is so beneficial, is because even though you've got this neurodegenerative disease going on, you're giving the brain the tools that it needs to try to rewire things, to kind of bypass the issue. And so it's huge. It's huge, absolutely huge. Other things that we talk about are diet. For instance, diet can be very helpful. A lot of times we put emphasis on the Mediterranean diet, and there are other similar diets out there like that. But when I talk about other lifestyle things that we can do, I kind of have a trifecta of exercise. So there's the physical exercise, which I've already harped on, but then I also consider cognitive exercise. So there are things that you can do to kind of keep your mind sharp. And I say, approach it like you would at the gym. If your arms were super jacked, like Dr. Kane's, then and you went to the gym, he shouldn't be working on the arms. He should be working on his chicken legs, right? So, I don't know what your legs look like. I'm totally kidding.
Chicken.
Okay, perfect. So, I got chicken legs too. It's okay. So, but you should work on the muscles that are weak. So think about the things in your mind that are weak. Work on the weak muscles. If you're good with numbers, then don't spend all your time doing Sudokus. Do the New York Times crossword puzzle. But if you're a master at the NY Times crossword puzzle, do a Sudoku. Mix it up to work on those weak muscles. And then the last one, which some people say, well, this is an exercise, but I call it social exercise. We know that social isolation, if there's anything that the pandemic has taught us, it's that social isolation is a big issue. It makes for breeding ground for depression. It makes everything worse. And you can get, having a neurodegenerative disease doesn't make you immune from those other things. So you throw on depression on top of Alzheimer's disease, that's awful. So social isolation is a big issue. Socialization is a way of overcoming that. And also think about what has to happen when you're talking with somebody. You've got to be able to listen to what they're saying, pull it in and understand it, all the while trying to think of something halfway smart to say back. And then when you start adding more and more people into the conversation, it gets exponentially more complex, not to mention the nonverbal cues. Your brain is working overtime when you're in a group of people. There's a lot to be done. So I consider it I consider it a form of exercise. So physical, cognitive, and social exercise. Notice that I'm putting a huge emphasis on lifestyle modifications, and we haven't even talked about medications. There's a reason for that, and I already told you the medications aren't that great.
Okay, so let me just, Dr. Tyson, if you don't mind, comment on a couple of quick things. Obviously, diet, exercise. In our community, we see a lot of diabetes, dyslipidemia, high blood pressure. You see a whole lot of vascular disease. Sometimes I get to am I looking at a vascular dementia, which is memory loss as a result of some, as our population generally says, mini strokes. uh, that term is used very heavily, but it can also be narrowed down to particular vessels in particular locations in particular parts of the brain that may cause deficient oxygen or deficient nutrients to the brain cells. And maybe that part of the brain gets damaged. And is that presenting like it's a dementia or pseudo dementia or whatever? So vascular dementia, we have to talk about, in terms of particularly in African American population, where the three entities I just mentioned is very, very high. Okay. The other thing is when we start talking about those tau and amyloid proteins being part of the brain, they if you look at it as a pipe way to your thinking, they tend to clog up the brain's ability to allow that thinking to flow through those avenues of transportation, for lack of better description of thinking. And then the last thing, um, when we start looking at, and I'm saying all this because of what you said, Dr. Tipton, just highlighting some of the things. Once before, it was most of the time we made a diagnosis for sure. We had a diagnosis of Alzheimer's was post mortem, meaning after you're dead. We biopsied your brain, and that's when we could say for sure it was Alzheimer's. We said clinically it looked like Alzheimer's, meaning that's how things presented throughout your life, but we couldn't say it for sure diagnosis that it was Alzheimer's. If I'm not, you can correct me if I'm mistaken, that if it was
Spot on.
Alzheimer's, that it was not made until you were actually dead. Things are looking much better since you mentioned, Dr. Tipton, about the evaluation, the radiological approach between PET scans and CAT scans and MRIs that look specifically for tau, and you're probably going to elaborate on this a little later, that look specifically for tau and amyloid proteins. It's a great advancement as it relates to when I started practicing medicine a zillion years ago, where what we were afforded then, and that was try this medicine, that medicine. I won't call them out, but none of them were any good. When the family says, "Oh, this really works great for my mother, my father, it's like I knew it was placebo, but I wasn't going to take away hope from it. So I
Ride the
said,
wave.
okay, I'm happy to hear it, and let it go on. And then absolutely the last thing is your making sure that we do the proper diet, proper exercise is okay, is great, and what we really need to do, because as you said, to get that kind of benefit from just the proper diet and especially exercise is tremendous when it comes down to treating those people with Alzheimer's. We do have a couple other things I want to touch into before we get back into the clinical research part. Um, as a primary care physician, when I get them to people like yourself, Dr. Tipton, and you come up with a diagnosis for sure, I now have to go back and talk to the family about not only what to do with them medically, which we are kind of talking about, but I also have to talk to what to do with them legally, financially, and protectively in terms of protecting your loved one. There are people out there, as we all know, are criminals. They look for the vulnerable. And there's no more vulnerable beyond children. Okay. Once you get beyond childhood, there's no more vulnerable than those adults that have dementia, and trying to be sure that they are protected against those criminals and whomever. So family needs to kind of step in, help put some legal barriers in place for people to come in and steal all the belongings, the monies, the what the people have accumulated throughout their life to help take care of themselves. The family needs to step in and help protect that individuals from those criminals. The other thing we want to make sure that they do is find, and that help can help be done by way of something legally, putting some things in place like guardianship. We need to make sure we help do that. And I know I'm talking advanced, okay, and we want to not get it to the advanced stages, but as it stands right now, we're going to see advanced stages until we know for sure, until we find that cure, for which Dr. Tipton, you will be talking about in a quick second. And so financially, you got to keep them guarded, and then physically, you know, can they still stay by themselves? That's a question to ask. That's a question that needs to be answered. Mom sitting at home 2 o'clock in the morning, open the front door and walks out down the street. What's going to happen? 2 o'clock in the afternoon, same scenario. Someone may find her. I found people, believe it or not, that had left a nursing home, and they didn't know who they were, where they were at. I was lucky enough, they were blessed enough that I happened to know what was in the area, and I got them back to the proper places. But it's really scary thought. So scary that that your loved one could be out. And I know people have seen news reports where somebody that has dementia can't be found. Where are they? Does somebody that is there someone who's willing to cause harm to them? Are they the ones in possession of this person? And so on and so on and so on. So that's a whole nother conversation that we can get into. But I do want to get into additional treatment. Somebody did ask about the benefits of vitamin supplementation. And then, of course, Dr. Tice, you can help guide it in terms of what next in terms of research and so on and so on.
Sure. Dr. Tippett, I do want you I want to circle back to the vitamins. And then I think if we have time, we can talk about what's on the horizon in terms of treatments. But vitamin supplements are available to folks. What's your take on the value in this condition?
Yeah, I'll give you a really short answer, and it's evidence-based. So replace the vitamins if they're low, period. There's no evidence that suggests going above and beyond normal values is beneficial. That includes vitamin D, vitamin B12, vitamin, you name it. And in fact, some of those vitamins, if you have elevated levels, can be toxic. So that's more of a reason not to do that. So we're not only talking about it won't help you, but it could even hurt you. So there's no reason from a neurological perspective to go above and beyond normal limits.
So what I hear when you say that, and I want to frame this for our listeners and viewers, that one, you need to be sure that you tell your physician that you're taking the supplement. Tell your physician if you're taking the supplement, and that there may in fact be harm that results for taking those if unnecessary.
Right.
So
Well, let me say this real quick, Kelly, and I say it to my patients, whether I'm not mistaken, Dr. Tipton, you can straighten me out right quick. But I do make sure that they are alerted. There are 4 main vitamins that I definitely don't want them to overdose on, and that is vitamin D, vitamin E, vitamin A, and then of course vitamin K. And the oils, the fat solubility versus water solubility, blah 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 blah. So at least those things, D, E, K, and A. K.
I remember
K,
it by Deke. Deke.
Deke.
It's a
I
terrible
used
name.
to say
Deke.
Deke at the same time.
That's the only way I remember it. Deke.
Exactly. I use Deke. Okay, so I'm sorry, Kelly. Go ahead.
Well, that's okay. I wanted to give us a time check because we are we're at the 7:30 hour. I know we wanted to give Dr. Tipton a chance to give us a little bit of a peek at what may be coming down the pipeline in terms of great treatments. Do you want to kind of close us with that?
Yes, Dr. Tipton, you can step up and let us know what you got going on, what treatments available, where the research is headed, and so on and so on.
Yeah, so the research that I think is really exciting that's going on and upcoming. First off, there's now it's not exactly prime time, but a blood test that can look for the amyloid and tau proteins. So no longer necessarily needing it's not as good as the spinal fluid, but we're working on ways to optimize it. But I mean, think about that, to go from having to get a spinal tap to getting, super expensive imaging to now a blood test. I mean, we're really moving on a long
Excellent.
way. That's even being used now in screening for clinical trials, for some clinical trials. So it's, it's going back to how expensive healthcare is. Clinical trials are trying to save money as well. It takes a lot of money to develop these drugs. And so oftentimes, or now it's kind of becoming commonplace to use one of those blood tests as an initial screening before you start scanning people. So these are going to become much more common moving in the future. In terms of treatment, and also I know we've been kind of hyper focused on Alzheimer's disease, but the biomarkers of other neurodegenerative see, I told you I stumble over it. Neurodegenerative diseases are not to the level that we're at with Alzheimer's disease, but we're moving in that direction. So I think Alzheimer's disease is going to be kind of the first domino to fall. But the other ones are clipping on the heels. So from the standpoint of treatments, everyone or a lot of people may be aware of all the FDA drama behind the approval of the medication called Aduhelm, or aducanumab is the generic form of it. Regardless of your belief system on this medication, and I'm going to keep mine close to my chest, it's being studied more. So this is a medication that, based on the FDA's approval, was stipulated on them doing an additional, what we call phase 3 clinical trial. So it's still being studied. It's a medication that directly targets that amyloid we've been talking about. And there are about a handful of other medications that work similarly that are very close to completion of phase 3 clinical trials, and some of those are looking very promising. One of those is being studied now with our first anti-tau drug. So, we talked about Alzheimer's being sort of a tale of two proteins, amyloid and tau. There's a study that's being done that's putting together an anti-amyloid and an anti-tau medication. So the field is really moving in that direction. And also with the advent and development of these better biomarkers, we're able to identify people earlier for these clinical trials. Because, you think about the trajectory of these neurodegenerative diseases being slowly progressive. The further you get down that slow progression, the harder it is to course correct. So if we can identify people early, even pre-symptomatic, we've got the greatest potential for change. And so those biomarkers are really helping us to do that. So I'm really excited to see what happens moving forward with trials of patients that have earlier or pre-symptomatic disease and these newer therapies. At Mayo Clinic here in Jacksonville, Florida, we're leading several research initiatives. We have an Alzheimer's disease research center. I believe there are 33 in the country, Alzheimer's disease research centers. And it's really the infrastructure in which we do research. Some of our trials are monitoring trials. So we have people that are coming in every year to have a cognitive battery and some testing. Some people are cognitively normal. It's important that we know what normal is so that we can know what abnormal is. Some people have diagnoses of Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, you name it, because we're trying to understand how these diseases play out. I told you that the temporal profile, the time change, the flavor of these diseases is very important. So we have trials like that. We also have different treatment trials as well. We're involved in some of those the anti-amyloid, anti-tau trials, and I expect for more to be coming. So we're always being presented with new things at Mayo, and I think it's an exciting place to do research. I will put a plug in for our brain bank. So we've talked about how previously the only way we could definitively diagnose Alzheimer's disease was by looking at someone post-mortem. So after they've died, they're done using their brain, and they've graciously donated it so that we can understand better. We have one of the largest brain banks in the world here in Jacksonville, Florida. And that includes many brains with Alzheimer's disease, many with other, pick your neurodegenerative disease. But that provides us with a very special gift, because donating your brain is one of the biggest gifts that you can do to help humanity and advance the science. But that is a great resource that we have here, and we've been able to make great advances in these diseases by leveraging the brain bank. So I think that those are the high points with research. Did I miss anything?
No, I don't think so. Well,
Okay.
a couple of things. I just need to comment. I don't mind donating that brain as long as it's not too soon. Don't take it too soon.
Agreed.
So,
I feel the same way.
And it's going to be your loss anyway. So, because you're going to find nothing in it. But, okay.
Yeah, I always tell people when they're getting evaluated for cognitive concerns, even if everything comes back normal, we're going to prove that you got a brain, so you can go back home and tell all your family, indeed, I do have a brain. So
have a brain. Well, one other thing I do want to ask, a couple quick things to say, is I've seen some literature. They talked about it. I don't know if you can comment, if you know anything about it. You probably know something about it, whether or not you want to comment. The Viagra, and some studies that talked about Viagra and dementia.
Yeah, I've had a few questions on that lately, and the idea behind it, at least as best I understand it, is through vasodilatation, and so meaning opening up the blood vessels. The idea, if you can open up the blood vessels, then you're supplying the brain with more of the valuable nutrients, oxygen, what have you, that it needs. It's certainly not at the point of prime time, and I don't know how that the evidence for use is that strong. I'm not at the point where I'm prescribing Viagra for people to prevent Alzheimer's disease. We'll put it that way.
Right. Yeah. Again, I guess if you also look at the number one cause of erectile dysfunction, winds up being high blood pressure, dyslipidemia, and diabetes, which affect vascular flow. It's not so far off in terms of why people think that way.
Sure.
Okay.
No, absolutely. I think it's a reasonable theory.
So the other things, real quick, is the different kind of clinical trials you guys may have available. You got the treatment trials, obviously, which says that we got some medications we may want to try on you, see if they work, don't work. You have your diagnostic studies, which you alluded to earlier, in terms of MRI, CT scan, PET scans. You have your prevention trials in terms of trying to see what can prevent it, i.e., in this case, what the best news we heard today with most of us is exercise, proper exercise. And then, of course, you got to put the proper diet. And I'm sure the two of those together is only going to magnify what each one by themselves would have done.
Yeah.
Uh, and then the quality of life studies, that's an important thing. How that person that has dementia, the quality of life is very, very important. I don't want my mom just laying up in a room somewhere and being able to say that she's alive because she has a heartbeat and I'm able to pass her on some food. I want her to have a good quality of life because I know for myself, if I can't have that quality of life, it's like, why am I here? Okay, if I can't enjoy that. And then the last thing that we're going to look at, and we can talk about all of this, can come back later because this is such a huge subject matter that we probably need to do another show on it. Is that online studies that can, you guys, these days there are a lot of studies that are being done with people online. And one thing that the pandemic brought out is that we're able to do a lot of things online that we had not thought about doing before, i.e., this conversation is taking place. This podcast is taking place online, even though I put up a whole studio and everything else, ready to take on this podcast. And here I am just doing plain online and didn't need all that expensive equipment. So, with that, Dr. Tice, I'm going to, with Dr. Tice, if it's something that you want to say, but usually we kind of let our guests say give a conclusion statement or a summary statement that they may want to give, and unless it was another question you had, Dr. Tice.
Not a question. I want to kind of declare the need for a second conversation about this. We've had more than an hour of discussion about what is an illness that has significant impact without the opportunity to really talk directly to caregivers,
Right.
And who are really integral to ensuring the proper supports. You alluded, Dr. Kane, to the legal issues and concerns, and we may have an opportunity to talk through what that really needs to look like. And then, of course, local support. So, navigating your community for your loved one to be sure that you've got resources. I want to bring to that conversation the challenges, the barriers that create and perpetuate health disparities related to that. Especially something you're seeing in an emerging field. It's not likely to be covered by insurance, and there'll be additional sort of challenges related to that. And so I think we can touch upon that in the second discussion. I know you all don't want to know it, but it's 150 minutes of sweaty exercise, hot, sweaty, tired. 150
That's right.
a week, 150 minutes a week. And Dr. Tipton, we'll let you have the last word.
Yeah, both of you really hit the nail on the head. As challenging as it can be to diagnose Alzheimer's disease, the most difficult part is managing the disease and managing expectations and trying. Our job is to help you peer around corners because we've seen the disease. It behaves differently in different people, but we should be able to help kind of guide you into what to expect and how to prepare. And an emphasis on the word prepare, because oftentimes people find themselves in a state of reactivity when it comes to these diseases. And that's the worst place to be in, because when you're reacting to something, you're already in crisis. Mm-hmm. And we're not thinking straight when we're in crisis. And there's a neurological basis for that we can go into in another time. But you're not thinking straight. And so you need to be known before you need to be known, I guess is one way of saying it. But I do think that it's important for us to have a deep conversation about managing, knowing when it's time to escalate a level of care. Again, everybody's different. It depends on on not only what the person's cognitive status is, but also what are their logistics? What's their family dynamic like? I mean, it's an incredibly complex thing. And so I look forward to that conversation with you guys in the future. So I would just say that it's exciting to see where we're going in terms of diagnosing Alzheimer's disease, in terms of treating Alzheimer's disease and these others. But it's really easy to fall into the doom and gloom of these diseases. And one thing that we've been kind of hyper focused on the medical side of things, this chronic progressive. I don't know how many times I've said that tonight, but just because there's a neurodegenerative disease at play doesn't mean that the person's not still in there. And so it's really easy to focus on, well, I got a memory problem. I've got a problem with this, a problem with that, a problem with this, and focus on the things that are lacking, the things that are missing, the things that the person is having difficulty doing. But if you're a caregiver, and you're looking at your loved one in that way, I would urge you to think about the things that they're still able to do, because they're in there. And sometimes it just takes a different way of approaching them to be able to access them. And sometimes you get creative, and you can discover new things about yourself too. Doesn't make it easy. But without getting too deep into that, because again, that's a whole podcast in and of itself. I mean, a whole legitimate podcast, not one episode of a podcast, a whole podcast. But I would say, as far as resources go, alz.org is a great resource. It's through the Alzheimer's Association. However, they've got resources that extend beyond just Alzheimer's disease, and it's a great place to start. So I would urge everybody to go there, check it out. There's even a 24/7 hotline for people that are basically in crisis. So please check that out. And those would be my final thoughts.
Well, and okay, so very good. The thing that I'd like to add to it, and that is, I think I'm going to go on ahead and put in I do have that URL for the Alzheimer's, and I'm going to have it loaded into our website because they have an excellent website where you can go get some of this help, and you can navigate it and explain some things. Very, very, very done very well. This is obviously part one. We need a part two, maybe even part three, because it's such an intense, such a broad subject matter. And like you say, with the baby boomers, like a better description, coming to an end, although they coming to fruition, because there's so many of us out there. I'm close to the tail end of it, but it's still 4 or 5 years beyond me that you still have these baby boomers. And so, and I think the size of the Alzheimer's population is going to get even larger, as all the statistics show. Hundreds of millions, and it's going to double that in a relatively short order. The last thing is, I truly would want to appreciate and thank both of you guys, and show you my appreciation of how important it was for you to come onto our broadcast and help explain to our audience exactly what it is that they're up against when they see dementia. Of course, we still have a continuing job to do with this, because there wasn't enough time. I knew that when we started, tried to get as much in as we can, but if you both are committed to coming back, we need to do this again.
Sure.
Absolutely.
All right. So with that, Dr. Tice, you got anything you want to add to it? So again, I want to thank all our audience for coming in. I can't go away without thanking our guru technology expert, Mr. Tyrone Jackson. Calltyrone.net. Okay. Dr. Tipton, I don't know if you heard the song from Erykah Badu, but it's called Tyrone, but never mind. All right. So thank you, guys. I appreciate everyone's patience. Sorry to take up so much time, but it's such a important subject matter that needs to be explored even more. So with that, I want to say good night to everyone, and thank you very much.
Thanks.
Thank you.
Thanks.
Thank you.